Greetings. My name is Andy Beltz. I am a physical therapist who has specialized in treating patients who are dizzy for over 20 years. I've been practicing since the year 2000, working with clients primarily who are only dizzy. So I have become very passionate about what we have to offer patients who are dizzy and off balance. I also love to teach about what I have learned over the years. And many times, I think I've had over 24 students over the years serving as a clinical instructor. And so over time, people have learned that I like to teach it. So my friends, my colleagues will often say, hey, I'd like to learn about vestibular rehabilitation. What courses should I take? So I decided that I would like to put together a video course that people can take at their leisure. This is also a course that I'm doing on site. So it's an opportunity for me to trial it out online and on video and see if it's going to work well. So thank you for joining me. And we're going to embark upon a 12-hour journey of what I have learned about treating patients who are dizzy and off balance over the years. So hang on tight. And I hope I don't bore you. I'll try to keep it exciting. It's pretty exciting to me. So first off, what I'd like to do is start out with the plan for the course. If you look straight ahead at this first slide, you're going to see what I call my mental map. This slide is full of clickable links of tools that you can use in the clinic. So when I have students come and hang out with me, I send them this slide because it has all kinds of tools that can be used, from how to do a history to the overall view of what vestibular rehabilitation is, to the oculomotor tests that we perform, and to treatments. So this is very valuable. And so this is kind of where I begin. This is how I view working with patients who are dizzy and off balance. And I have found this to be very successful for my students as they also learn about how to provide vestibular rehabilitation. So we're going to go off of this main slide. You are going to get to know this slide very well. And the plan is that for the first hour of this course, we are going to provide an introduction on vestibular rehabilitation and kind of an overview of the big picture. So we will cover the following objectives. The first objective is we're going to briefly describe the history and the impact of our founding vestibular specialists, Cawthorn and Cooksey, Brandt and Daroff and Epley, on helping clients battle dizziness. So I think it's helpful to get the history behind how did vestibular rehabilitation begin. Then we're going to name major causes of dizziness, and we're going to discuss their prevalence. And we're going to define what in the world is vestibular rehabilitation. So we're going to define what it actually is, hit some of the key points behind it. Then we're going to list the 4 major types of vestibular rehabilitation, and we're going to give an example of how and when each would be used. Finally, we're going to name the 4 most important goals of being a vestibular rehabilitation therapist. So that's where we're heading for this first hour. For the whole course, we will be following the applicable anatomy and physiology. It's absolutely amazing. How is it that we have good balance and that we can see clearly when we move? Then we're going to hit the pathophysiology. We're going to cover rocks versus stroke and other dizzy competitors. What are the major reasons people get dizzy? And how do we figure out why people are dizzy and what goes wrong? We're going to cover the main top reasons for why the patients who I've seen in the clinic over the last 21 years get dizzy. We're going to cover the history-taking process, key questions to ask. We're going to follow an algorithm of how to take a good history. Then we are going to we're going to learn how to do a vestibular examination for patients who we do not believe have BPPV. We are going to learn how to do a vestibular exam for people who we do believe have BPPV. We're going to cover how to treat patients with BPPV and how to provide treatments for all the other types of dizziness that we see. So we're going to cover all of that first within the first 7 or 8 hours. Then we're going to practice, practice, practice. We are going to go over some case studies that will help us understand how to apply everything that we just learned in the prior 8 hours. So I hope that gives you a general idea of where we're heading. Let's dig in. This is very exciting. So first off, what is the history of vestibular rehabilitation? Well, can you believe that in the 1800s, all that we knew was that inner ears were responsible for sound? We had no idea that they did anything for balance until the 1900s. And it wasn't until the 1940s when two physical therapists named Cawthorn and Cooksey learned that they could help soldiers who were dizzy with what we call habituation exercises. If you have them move their eyes and move their heads in a certain organized manner, repetitively over and over, that will actually help people feel better. Then in 1952, two individuals named Dix and Hallpike learned that there is this type of vertigo that is related to positional changes. Then in 1962, Harold, I won't even try to pronunciate his last name, Shuknik, he proposed that these positional vertigo was from chalk-like particles that could be inside the inner ear, but we still weren't sure what to do about that. It wasn't until 1980 when John Epley, accompanied by his audiologist, Dominic Hughes, figured out that there could be a way to potentially put these calcium crystals back where they're supposed to go. Pretty amazing stuff. But they were met with great resistance when they tried to present their idea to the Journal of Otology and to their peers at conferences. Now, while they were meeting resistance, there were other physicians named Brandt, Daroff, and Simont that were finding that there were certain types of maneuvers you could do to people that would kind of habituate their dizziness and over time help them get better faster. So kind of in addition to what Cawthorn and Cooksey had to say. As time went on, John Epley continued to face resistance, but it was in 1992 when his article was published in the Journal of Otolaryngology, and it was published that he could have a 100% cure rate performing his maneuver on 30 patients. Time continued on. In the early 1990s, vestibular rehab concepts began to be taught in the NCS, the Neuro Certified Specialist exam for the American Physical Therapy Association. One of my colleagues, one of my mentors, her name was Marcy Stalvey at Edwin Shaw in Akron, Ohio. She was one of the first to take a class on vestibular rehab concepts in her NCS exam, and she attended one of the first competency-based courses that was put on by Dr. Susan Herdman. That was in 1997. So in 2001 is when I attended Susan Herdman's course at Emory University. And I remember it was around 2001 when I was actually told that vestibular rehabilitation was voodoo, that a neurologist told a patient, he said that whatever Andy is doing, it's voodoo. It's not really true science. And I remember being so offended, but it turned out that that neurologist was one of my #1 referral sources as time went on. So that kind of gives you a little background of the history of vestibular rehabilitation. It took time for it to catch on, and it really wasn't until the end of 1990s to the early 2000s when vestibular rehabilitation first began being practiced. And I remember it was also 2001 when a neuro-otologist, Dr. John Ose, he was from the Cleveland Clinic, he would send me patients for them to receive therapy on their necks for dizziness. So cervicogenic dizziness was very controversial back in the day. And he he kind of was a pioneer in using neck therapy to help patients who were dizzy. And so that kind of gives you an idea of where we've gone, where we've been, and kind of why we are where we're at this point with treating patients who are dizzy and off balance. We have a lot to owe to these awesome individuals who started what a great type of physical therapy and vestibular rehabilitation for people. So what fascinates me is the amount of scrutiny that John Epley went through, and he persevered, and now he is helping millions and millions of people who are dizzy. So let's go back before we move on here and just look at this major overview. Now that you know the history of where this began, let's cover why it is that we get dizzy. So first off, I would like to share this major slide. If you will, imagine having a patient and they're sitting in your waiting room. We're going to look at this from an outpatient perspective, but if you are an inpatient therapist or you are a hospital-based home care patient, home care therapist, wherever you're located, this is a approach that you can use to help your patient with dizziness. So first off, they say they're dizzy. What's going through my mind as I am walking up to get them out of the waiting room is, I know I have a patient with dizziness. I wonder if their dizziness is coming from their ears. Is it coming from their brain? Is it coming from their eyes? Could it be that they have a blood sugar issue? Are they taking too many medications? Is there a heart issue involved? Could there be a neck issue? Could there be neuropathy? So those are the big reasons that people can be dizzy. And I have learned over the years not to ask if they are dizzy because of their ears or their brain or their eyes, but I have learned to ask and or. So if you look in this corner, you'll see an and sign and an or. And I've learned it's usually not just one thing. It's usually several different things. And so when you're trying to think of why your patients are dizzy, don't think of it as being one problem. Think of it as more likely to be 2 problems or 3 problems or 4 problems, okay? Now, when we talk about the inner ears and the brain, that makes up the peripheral and the central vestibular system. So if you look at your slide here, you'll see that the vestibular system is made up of the central vestibular system and the peripheral vestibular system, okay? There are official words that we give the peripheral vestibular system, and that is for the inner ear, that is the peripheral vestibular system. And the official word we use for the brain part of the vestibular system is the central vestibular system. Now we're going to dive in deeper to what all this means, but there are 2 major peripheral vestibular problems. There are hypofunctions and there are hyperfunctions, okay? And we'll go into what all the different types of problems that can come from these. But when a patient has a vestibular problem, think peripheral vestibular, central vestibular, and we will define what makes all those up. So when a patient's dizzy, we're thinking, could it be coming from their inner ear and their eyes and their blood pressure and diabetes and heart issue and possibly a problem in their brain? But when we really want to narrow it down to the vestibular system, we're talking about their peripheral and their central vestibular systems, okay? Because that is what we do vestibular rehabilitation for. Now, there are 4 main types of vestibular rehabilitation. They are adaptation, substitution, habituation, and repositioning. And you'll see there that there's a type of problem that we use each tool for. And the point of what I'm about to share is so that you learn when to provide each type of vestibular rehabilitation at the right time. Vestibular rehab works best with stable peripheral problems, but it does not work so well with unstable problems. So we're going to talk about how do you know if it's stable or if it's unstable, okay? So that's the big picture of dizzy. Somebody says they're dizzy. This is the map that is going through my mind. Is there an inner ear component? Is there a brain component? Are there other reasons for dizziness? But what I'm known for, what I'm famous for, haha, famous. In your own little world, you will become famous when you do this because people will be so thankful for the type of therapy you can provide. But when it is their inner ear, if it is the calcium crystal problem, for instance, how do I know what type of therapy I should provide? Okay. So I've got to figure out why my patients are dizzy and which tool, which type of vestibular rehabilitation I'm going to use to help them get better. All right, let's move on. Now that you know the big picture, let's talk about why it is that our patients really get dizzy. What are the most common reasons that you're going to see your patients in the clinic? Why are they going to come to you with dizziness? Well, as you can see here, Timothy Hain put together some research studies and some different information, and he believes that about 50% of the reasons that patients get dizzy is due to inner ear and brain. And as you can see, 40% of the time, it's going to be inner ear problem. 25% of the time, we don't know exactly why patients are dizzy. And the other 25%, it's more medication, more heart, more related to toxicity and other types of things. Now, why do people have acute sudden dizziness? It's about the same. So patients who are going into the emergency department, who suddenly wake up and they're dizzy, it's about the same type of picture. It's most of the time going to be inner ear, maybe a little bit of brain, and non-stroke, non-cardiovascular reasons for dizziness that people are going to have that. So this kind of breaks that down. The dangerous cases are the ones we worry about the most. And the dangerous cases, as you can see, about 9.7% of the time, it's going to be due to acute coronary syndrome. About 18.3% of the time, it's going to be cardiac. About 23% of the time, it's going to be cerebrovascular disease. And about 32% of the time, a fluid or electrolyte issue. So about 15% of acute dizziness is dangerous overall. As physical therapists, we won't see a ton of these cases until patients have gone through the emergency department. But there are times when I'll have patients actually come into my clinic with sudden onset of dizziness. So I always keep these slides in mind that dizziness can, of course, sometimes be life-threatening, and it's my job to be able to try to figure out when it is and how to know. This is a study that we did on around 400 or 240 patients. At the time when we crunched these numbers, we had about 70, I think we had 48, we had around 231 patients come in, and we found that about 183 of them had just the general diagnosis of vertigo. And the other 18.6%, other 43 had actually the diagnosis of BPPV, and about 5 patients had the diagnosis with a hypofunction. So as a physical therapist, you're just pretty much going to see the diagnosis of vertigo, and then it's going to be up to you to figure out what's wrong with your patients. And what I found in my clinic, out of those patients, 54.1% had BPPV, 22.5% had what we call vestibular hypofunctions, and 23.4% had other reasons for their dizziness that I can go into more later. So the main point here is that you need to know how to tell if a patient has an inner ear or a brain problem. And I'm going to teach you how to do that now. So let's get to the good stuff. What is vestibular rehabilitation? So that really depends on who you ask. Vestibular rehabilitation is defined in many different ways. And so I've got some official definitions here for you, and then I'll give you my opinion on what it is. Some would define vestibular rehab as an exercise-based treatment program designed to promote vestibular adaptation and substitution, where the goals are to enhance gaze stability, to enhance postural stability, and to improve vertigo. So you want to help a person see more clearly when they move, you want to make them more balanced, and you want to get rid of their dizzy feeling. What I like to say is that vestibular rehab is therapy that's aimed directly at improving the functional relationship between the inner ear, the brain, the eyes, the muscles and nerves, so the central nervous system, and through central nervous system compensation. It's also therapy aimed at getting rid of mechanical problems within the inner ear causing dizziness. At best, vestibular rehab is a systematic method of constantly evaluating and adjusting use and dosing of 4 major treatment tools based upon the response of the patient with dizziness to treatment. So vestibular rehab really is a systematic approach to helping patients get rid of their dizziness. And at worst, it's when, someone just says, here, you're dizzy, try these exercises. We have no idea why you're dizzy, but try these exercises. And if they help, then good. So that is kind of what's done out there. Vestibular rehab is an essential element of fall prevention programs, and it is cost effective. It is one of the few types of therapy that can take a person's problem away in one visit, and it can significantly improve the sensation of dizziness from 1 day to 6 weeks. So it is evidence-based, and it is a very cool type of therapy. And as I mentioned before, there are 2 major types that make up 2 parts that make up the vestibular system. There's the peripheral and the central systems, and stable lesions of the peripheral vestibular system work best. So our objective is to get the lesions, or the reason that patients are dizzy, to stabilize it. And if it's unstable, we've got to refer those patients on to get stabilized. Stable central lesions can get some help with vestibular rehab, but stable peripheral lesions are the best, and unstable central lesions can be dangerous. And so we definitely need to know when to refer these patients on. But we treat all of these differently. So what you have to do is you have to know the most accurate diagnosis to help these patients. And it helps to have good, strong teamwork with other healthcare providers. And you've got to know your limits when to refer. Now, I love this next slide. This is the definition of evidence-based therapy. And this is how we get optimal patient outcomes. We need to have our clinical expertise combined with scientific research, and include our patient's values and circumstances and kind of what the patient wants with what's out there with evidence, with our experience. We put all that together, and that's how we get our optimal patient outcomes. And I like to say that's the sweet spot. My son Liam loves to use wooden bats to play baseball, and he has learned that if he's going to use a wooden bat, he's got to hit the ball right on that sweet spot to get the most pop, to be competitive with his friends who are using metal bats. And so I think this is the sweet spot when we provide vestibular rehabilitation, combining all 3 of these elements. Now, what you might be thinking, if you're like me, one big concern was just that you are being safe, that you are, that your patient is safe, that nothing bad or serious is going to happen, that you're not going to miss anything. And our patients want to be safe. They're worried that there's something more serious going on when they're dizzy. And so our most important goals to help these patients is there something life-threatening going on? Is our client safe? Is there a central and or peripheral vestibular problem going on? And are those problems stable? So those are the big questions that we have to answer when our patients are dizzy, okay? And are there other reasons? Could there be a heart issue? Is there something? Could they be in the 15% of acute dizziness of something serious, something life-threatening going on? And then our other major goal is, when do we refer these patients? Who can we help? Do we know our limits? Who can I treat? Who can I help? And who should I refer on to another healthcare provider? Do I refer them back to the evaluating therapist? If I'm an assistant, if I'm a PTA and I'm doing therapy, should this person go back and see the evaluating therapist? Or if you're the evaluating therapist, should you send them back to the doctor who sent them to you? Or should you send them on to someone who specializes in vestibular rehab all the time? Those are some big questions. And so once again, big things on your list. Is the problem stable or unstable? Are we in the acute phase, the subacute phase, or the chronic phase of the disease that's causing their dizziness? And do I know which type of therapy to provide these individuals? And can I provide the proper treatment options for these patients at the proper time? So if you're the therapist, can you tell if a person is dizzy, if it's due to their inner ear and or their brain and or their heart and or their eyes and or their neck? Can you tell when the problem is stable, when it's unstable? And can you figure out which type of therapy to provide at the right time? That was a lot of information. And if you're sitting there and you're saying, boy, that sounds complex, I don't know if I can do that or not. Well, I'm glad you're going to join me in this course, and I look forward to getting to the good stuff with you. Let's see if we have covered our objectives for the first part of this course. So for the first section, we wanted to briefly describe the history and impact of the founding vestibular specialists, Cawthorn, Cooksey, Brandt, Dorff, and Epley, on helping clients battle dizziness. And so you really learned in that part that vestibular rehabilitation has really only been performed since the late 80s to 1990s. And you learned the key names of individuals who provided that type of therapy. We did cover the major reasons why people get dizzy. Using the mental map there. We defined what vestibular rehabilitation is, and we listed the 4 major types of vestibular rehab, being adaptation, substitution, habituation, and repositioning. And we very briefly talked about adaptation. You'd use that for a unilateral vestibular loss or a bilateral vestibular loss. Substitution you would use for inner ear problems and brain problems. Repositioning you use for BPPV, and habituation you use for reproducible forms of dizziness. So we'll go over that more. And then we named the most important goals of being a vestibular rehab therapist. Is the problem stable? Is there something life-threatening going on? Is the problem coming from their inner ear? And who should I refer back? I guess those aren't the most important, so sorry about that. According to this slide, these are the 4 most important goals. Is there something life-threatening going on? Is there a central and or peripheral vestibular problem going on? Is it stable, or are there other reasons for their dizziness? Maybe I could update that slide a little bit, because I think some of those could all be under 1 or 2 of the most important goals, with the next most important goal is, can I treat this person? And if not, who should I refer that person to? So I hope that helped. That concludes the first section of our course. Where we're going to be heading next is the anatomy, the physiology, and the pathophysiology of dizziness. What do vestibular clinicians really need to know? And this is fascinating. This is exciting. So I look forward to sharing this with you all. I will see you next.